So today what we're going to talk a little bit about is evidence-based medicine. I think everyone has a general idea of what that is when we say evidence-based medicine, what we're talking about. But hopefully what I'm going to give you today is just some tools to use as you move forward with searching for evidence, evaluating evidence, that kind of thing. You're going to use this for almost everything you do for the next 2 years. Right now, probably most pertinent is seminar, right? Everyone's working on a seminar trying to find evidence. How many people did their search the first time and got, 100 hits and trying to figure out how to narrow it down and what to do? So we'll talk a little bit about that. But even more so, as you do journal clubs, moving forward, taking care of patients, making decisions about patients, you need to be able to actually analyze the information that you're finding. So we're going to talk a little bit about all of those things. Okay, so these are our objectives. We're just going to define evidence-based medicine, talk a little bit about how to integrate evidence into your practice, how to get the most out of your searching. So how many people have ever heard of PICO, P-I-C-O, that process? We'll talk a little bit about that. And just retrieving the evidence and actually analyzing it and applying it. So that's what we're going to try to focus on today. Okay, so which one of the following do you think best represents the definition of evidence-based medicine? Rigorous research, expert opinion or clinical judgment, patient values and preferences. Which one do you think is evidence-based medicine? If I call on you, just press the button so everybody can hear. Anybody have an idea? Sarah, you look like you have an idea.
Is it rigorous research?
Okay. How many people agree with that? All right. Anybody want to try one of the others? It's a little bit of a trick question because I think that when we think of evidence, it really is, what does the literature say and what's been published on this. But in reality and in practice, really what it is, it's the integration of all three of those things. And evidence alone is really not enough. When you're making a clinical decision, there's so many other things that might come into play. So I always like to use the example of, let's say a patient comes in, it's a trauma, they come into the emergency room. The best thing for them, based off the guidelines, would be for them to receive blood. Well, maybe, because of their religious beliefs or something, that maybe that's not the best thing for the patient. So even though it's the best evidence, it might not be the best for that patient. So you've got to incorporate all those things. Maybe basal bolus is the best regimen for a type 2 diabetic, but somebody can't afford that. Well, maybe it's not the best for them. So you do need to incorporate the patient preferences and their values, as well as clinical judgment of the provider. So the physician may, just based off of his experience and the things that he's seen, maybe he knows that this would not be the best for the patient. So kind of all those things go into the evidence. Okay, so why is evidence even important? You think about some of the things that have happened in the last 5 or 10 years, or even in just, going back even further than that. Everyone probably remembers the Michael Jackson situation, right? He died because he was receiving propofol at home. So if you looked at the evidence, you look at how we actually use propofol in the institution. Most patients, because it has anesthetic properties, because it lowers blood pressure so much, most of the patients in the hospital who get propofol are on a ventilator. They're being constantly monitored. We have very strict guidelines about sedation in the hospital, where it can be given, what can be done. But then yet this happens where he's getting it at home for sleep, and he wound up dying from that. So evidence is important to prevent things like this from happening. Also just for legal reasons, just for accountability, whether it be legal or be financial. So many payors really require that providers are following the best evidence when making decisions, because that's basically what leads to the best outcome. So a lot of these things kind of go into play for why it's important to incorporate it into your practice. two major principles we're going to talk about throughout this presentation today. The first is just a hierarchy of evidence. And then we're going to, we've already sort of alluded to this, is that evidence alone is not the only thing you have to consider when making a clinical decision. You have to think about cost, convenience to the patient, values, that kind of thing. Okay, so let's talk about 4 steps for incorporating evidence into your therapeutic decisions. Okay, we're going to walk through each one of these, formulating a question, searching for the evidence, evaluating, and applying. So, you know, the very first step, and if anyone has had me as a seminar advisor or anytime you're doing a presentation, the first thing I probably ask you is, what is the question that you're trying to answer? It's kind of like finding a needle in a haystack if you can't really pinpoint what it is you're trying to answer. And that really should be the basis of every time you're using the literature. It's like, okay, I have this specific question. I need to answer this for, you know, taking care of my patients, or it's adding new knowledge, it's going to change the way I actually practice. But you've got to know what you're looking for. Otherwise, it's really broad, and you know, you wind up getting a lot of, you know, especially when you're searching, you know, a lot of things that are really not relevant to what you're looking for. I'm talking a little bit about the search, talk about the evaluation, and how to apply. All right, so let's take a look at this patient case. This is a 50-year-old male who comes, he's just, let's say that he's a person that comes to your store regularly, you have a relationship with him, he always talks to you about what's going on with him medically. He's 50 years old, he has type 2 diabetes, and his blood pressure has been running high. So they've been checking it over the last few months, and it's continuously running just a little bit higher than what they would like. You know, but he's not on any medications. He's been trying to deal with this with diet and exercise. He really doesn't want to go on medication. So he comes to you and asks your opinion on whether or not he should go on medication or not. And you're going to do a search for him and try to see what the evidence shows, okay? So which of the following would be the best clinical question based off of this information? Okay, the first one is, in a 50-year-old man, which antihypertensive agent reduces systolic blood pressure the most? The second one is an ACE inhibitor better than a diuretic in a 50-year-old man with type 2 diabetes? The next one is, does blood pressure control with an ACE inhibitor reduce morbidity and mortality in a 50-year-old male with hypertension and type 2 diabetes compared to placebo? And then, what is the blood pressure target for a 50-year-old man with type 2 diabetes? Okay. Alicia, what do you think?
C.
All right, why? Okay, so that's correct. Why did you pick C as the best question?
Because it's the only one that shows him what would happen if he doesn't take any medication.
Okay, so you're talking about the morbidity and mortality. I think when we do searches, most people are really good about talking about patient population and probably the drug that they're evaluating, but we tend not to be as good about including things in our search related to the comparator or specifically the outcome. And picking an outcome, I call them points. You might see them referred to that way if you ever look. Points are, and we're going to talk about this a little bit more, but patient-oriented evidence that matters. And this is in your handout a little bit later. So when we talk about that, what we're talking about are things like decreased mortality, you know, decreased risk of stroke, you know, things that actually have impactful meaning to the patient and the, you know, people taking care of the patient. On the other hand, there are DOEs, I call them DOEs, or disease-oriented outcomes. Those are more like surrogate markers. So let's say it may lower a certain lab value, but in the end, it really doesn't do anything for improving survival or anything else. And we'll talk about a little bit about why that might be a problem a little later, okay? Okay, so this is correct. Number C is the right answer. And when you think about the PICO, I I say PICO, it may not be called PICO, but it's easy for me to remember PICO. When you're doing a search, if you just kind of think about this, always include terms that relate to each one of these sections. It will really clean up your searching, okay? You'll get things that are much more relevant. You don't have to go through 100 things to find the top 3 that really matter to you. Always include terminology related to the type of patient population you're talking about. It may be a patient characteristic like elderly. It may be a disease characteristic like diabetes. So including something related to the type of patient you're talking about. What is the intervention? And these things can be very specific or very broad. You could be as specific as saying an ACE inhibitor, or you could be as broad as saying, a more broad treatment. What is the comparator in the case that we're talking about with this person? It's placebo, right? Do nothing or actually treat. And then the outcome. Again, points would be preferred because those are things that really matter, okay? I sometimes like to throw in an S on the end of PICOs, something related to the study design. So depending on, and I have some tips for you later on about depending on what type of outcome it is that you're looking for, some things you can include related to study design. So whether it be a controlled trial, but maybe a controlled trial is not the best thing. Maybe it's related to harm. We're not going to do a study and make people smoke to see if it causes cancer, right? All those kinds of things are generally done observational, right? Because it's by happenstance that they happen to have whatever it is that you're looking at. But you're not going to force somebody to do something that's going to cause harm. Okay, so including something related to that will clean up your searching even more. Okay, so focusing the question, it streamlines your search. It also lets you know, helps you with the external validity of the trial. What I mean by that is how well can you apply this to the patient population that you're taking care of. So you're over here at MCG, you do a study, let's say you're looking at a study, 95% of the people were white males, aged 50 to 60. Well, that's a very specific population. Maybe at our institution, that's really not as applicable. So how well can you actually generalize the information? Answer a question, provide new knowledge. So when you're doing a search for any reason, these are the things you should be thinking about in your head. Does it answer a specific question? Does it provide new knowledge that's going to change the way I'm going to treat? Does it help, is it specific to the population that I'm talking about? Okay, so just kind of filling in, this was a 50-year-old male with hypertension and type 2 diabetes. Let's say we just picked ACE inhibitor. Again, you could be more broad with this if you wanted to. Placebo was the comparator, and then the reduction in morbidity and mortality was the outcome that really was important. Okay, so let's talk a little bit about searching the best evidence. Sometimes I don't feel like this is where students struggle so much. I think even it may not be totally efficient, that maybe you have to go through some things, but if you follow some of these tips I'm telling you, it will definitely clean up your searching. I feel like the part that students struggle the most with is the actual analysis of what they find, like what do you do with all that information that you find. I think students are fabulous at summarizing the information they find, but actually analyzing it is a little bit harder. So we'll talk a little bit about how you can get better at analyzing the information versus just summarizing the information. Okay, so let's see. Is Baron here? Ben, you just had your
I don't think
you just did your clinical seminar.
Dr. May, I'm in Athens.
Oh, okay. All right, there reminds you too. Ben, you just did your clinical seminar. What was the thing you struggled the most with as far as when you were searching for the literature? Like, what was your biggest struggle?
I would say my biggest struggle would be, or it was, narrowing down my search. Like you mentioned earlier, like when I first started searching, I was getting like a lot of results, too many to pick one article from. So I was just like focusing on what I wanted to, how I wanted to narrow it down specifically, like what question I wanted to answer.
Yeah, so first you gotta know what you're trying to answer before you can even find what you're looking for. Baron, what was yours?
Since my drug was new, so it was kind of easy to find them, but I guess just finding trials that fit my topic particularly.
Okay, yeah, that's the problem when you have such a new drug that there might not even be a trial published yet, so just trying to find the evidence. Okay, so let's just talk a little bit about how you can actually search the evidence. There's 4 ways that I can think of that you can search, and in any given situation, one might be better than the other. If I'm sitting in my office and I have a quick question about stroke, I'm probably not going to, maybe I won't do a search. I'll run around the corner and talk to Dr. Fagan, so you can talk to an expert in the area, and it's really nice, like being here. We have so many experts in different areas, and sometimes it's nice just to get their opinion about, what the best thing to do, like a kind of a curbside consult. And that's really good, as long as they have stayed up to date on the information, and that they don't have a particular bias. So maybe they're really biased in one way, like we should always do it this way, and they don't even bring up the other way. So, making sure it is balanced and it actually includes maybe all the options that are available. But that is one good one. It's easy, it's quick, if you need that, that is one option. Practice guidelines, that's a really good way. Practice guidelines are nice because it actually summarizes all of the data that's already been published, right? So it kind of gives you recommendations based off of the level of the evidence. Maybe this is the first thing you do, maybe this is the second thing you do. The third thing you can do is look at systematic reviews and meta-analysis, and that is almost, if you think about it, almost like a really specific guideline, because if you think about why we do systematic reviews and meta-analysis, it's really for those things where we're trying to answer a very specific question, or maybe the data is controversial. Maybe part of the data says, yes, this is a good thing to do, and part of it says, no, it's not. And by putting it all together, we're increasing the power if we do a meta-analysis, so maybe we can find something out about that. As a drug information person, when I do monographs for the P&T committee or class reviews, I tend not to use meta-analysis just because of what I just said. You're usually trying to answer one very specific question. So for the case of when you're trying to consider something on the formulary, it might be better to have it a little bit more broad and look at all the evidence individually. And then the last thing is just do your own Medline search, and there's several secondary resources that you can use for that, whether it be Medline, PubMed, Galileo, and Ovid. And for the longest time, this was something that was very confusing to me, is like, how are those all different? Like, what's different about Ovid versus PubMed? You guys primarily use PubMed? How many people use Galileo? Anybody? Yeah, a couple. I always tended to use Ovid here because that was what we had here, and I think the filters are like a little bit, there are more filters and a little easier to use on Ovid, but we'll talk a little bit about the differences. Okay, so which of the following can be considered the best evidence? Aaron.
We'll help you.
Yeah, y'all can help.
Randomized control.
Okay. See, I'm throwing a lot of trick questions at y'all today. Any of these we think about randomized controlled trials, right? And we're going to talk a little bit about pyramid in a minute. And it is, because that is an experimental trial where you give them some intervention and you're looking for whatever that outcome is. So that is really great. But think about pediatrics, or think about some very rare disease. Sometimes we just do not have a randomized controlled trial. So the best evidence is whatever evidence is there. Sometimes it is just a case report. Maybe we have this really unusual poisoning, and there's this antidote that, this odd drug that's never used for this, but maybe it's used for this. For At P&T, we were talking about anakinra for macrophage activating syndrome in pediatric patients who have rheumatoid arthritis. Very specific, right? So we probably, at best, we had some cohort studies of case control studies. We did not really have a randomized control trial. And all the trials were like 12 patients, something really, really small. So the best, whatever the best evidence is, sometimes it is just case reports. But if you are faced with a situation where you have a choice of a randomized control trial or an observational study, you probably would pick the randomized control trial, right? Because at least it's experimental. You actually made an intervention to see versus something that is just observing. So there is a hierarchy for that, and this is basically, you'll see things flipped around a little bit, but expert opinion is kind of down at the bottom. It is considered evidence all the way up to like a systematic review or meta-analysis. So the randomized trials are right there, close to the top as well. But again, the meta-analysis and the systematic reviews are going to be very focused and specific. So you're not going to be able to use those like you would maybe a guideline. Okay, I really love this slide because this is another thing that always confused me. It's like, okay, there's so many different types of trials. And how do I decide which one I want? Get faced with, all of these, which one would I actually pick? So I like this because I think it breaks it down in a way that's easy to understand. So you have primary studies, you have secondary studies. So if you think about those secondary studies, those are things where the evidence has basically just been summarized for you. So they take the studies and they summarize the evidence. So that would be things like meta-analysis, systematic reviews, guidelines, that kind of thing. And systematic reviews, it's not a review article. A review article and a systematic review are not the same thing. A systematic review, there's if you go to the Prisma, we'll talk a little bit more about that in a minute, that you can find a checklist of all the things that have to happen to make something a true systematic review. It's very structured in what can be included and how they can include a study or not include a study. But it does summarize a study, and it's probably best when the outcome is maybe not clear, controversial evidence, or if you're trying to answer a very specific question where you're adding a lot of the evidence together to increase your power so you can see if there's a difference. A meta-analysis is just the next step above a systematic review where you actually are applying statistical analysis to that to look for the differences, basically. So if you ever do record in any of your seminars on a meta-analysis, make sure you record the I-squared statistic because that is telling us how heterogeneous your patients were. How different were they? If they're really different, you're going to need more people to see any kind of difference that you're looking for. So less than 25 usually means that, that's good. You want that number to be low. It means that your patients are more homogeneous versus greater than 75. Sometimes they might say 50%, but definitely at the higher end, that's just showing that maybe the studies were really different. So maybe a little harder to see the evidence. Okay, so then on the other side, we have the primary studies. There we have experimental studies and observational studies. So the experimental studies is where you actually do an intervention. So those are your control trials. Now, they don't necessarily have to be randomized. They can be randomized or non-randomized, but most of them are randomized. And usually, you think about incidence. What is incidence? Can anybody define incidence for me? And you guys on the distance sites, feel free to jump in if you want to. Aubrey, you look like you have a
My
thought.
mic's broken, so Ben's gonna speak for me.
Oh,
The
okay.
occurrence rate or the frequency.
Dr. May,
Yes.
is it a number of new cases?
Yes, it is. Yes, it is. Okay, so new cases over time. Ben, thanks for trying over there. He couldn't get his microphone working. Okay, so yeah, new cases over time. So think about it. That's what a control, if you think about prospective trial, that's what we're doing. We're giving them an intervention. We're following them over time to see if they actually develop the outcome. They don't have the outcome when you start, okay? That's a prospective study, okay, and experimental trial. Okay, so how is that different than an observational trial? An observational trial means you're not making any intervention. You're basically observing. Now, these tend to almost always be retrospective studies because it's like watching paint dry, right? I mean, like if you're looking for an outcome that may not occur for 10 years, it's really hard to do that in a prospective manner. So they tend to be retrospective studies, but the cohort can be retrospective or prospective. Now, this was like, blew my mind. It took me forever to really figure out what that meant, but I'll give you an example in a minute. Okay, now the problem with observational studies is that we're not making an intervention, so you cannot show cause and effect with an observational study. All you can really do is show an association, okay? That's why we use relative risk, that's why we use odds ratio. It's an association, measures of association. One thing might be associated with something else, but not necessarily cause it. Okay, but with experimental trials, because you are making an intervention, that is how you prove causality, okay? Okay, so under observational studies, you have cohort. We just said that the study itself tends to be retrospective in nature, but the cohort itself can be either prospective or retrospective. And then you have case control trials. Usually that's where you're starting with the outcome already, all right? So we can't do incidents. And you're looking to see if they develop, what risk factors did that person have to actually develop that disease, okay? And then all the way down to case reports. Okay, so with observational studies, you attempt to establish association, but you cannot show causality, okay? All right, now this is what I mean by it can be a prospective or retrospective cohort. Okay, so let's say you're doing an MUE at the hospital, and you're going to present this as your poster for mid-year, right? They are probably going to run a report and give you your patients, okay? Which means that all of that has already occurred. You're not doing anything prospectively in the sense where you're starting here generally. It's all retrospective. It's already happened, and they're going to give you a report. Okay, what makes it a prospective or retrospective cohort is that let's talk about the risk of kidney disease with PPIs. It's a prospective cohort if you start them on if you look at patients who are on PPIs and you look to some point in the future to see if they actually develop CKD. Now, it's already happened in the past, but you're starting with people who had the PPI and then you're looking to see if they develop CKD. A retrospective cohort would be, we have these people who develop renal failure, and we're going to look back to see if they were on a PPI. So it's just, are you looking at it from the perspective of the outcome or the exposure? Does that make sense? Okay. So you cannot calculate incidence if it's a retrospective cohort. If you already have the disease, and you're just looking back to see if they developed, or what risk factors they had, you can't calculate an incidence because they already have the disease. So in that case, you cannot use relative risk, right? Because relative risk is basically a ratio of the incidence of those exposed versus those not exposed. This is where you would probably see odds ratio used. You already have the outcome, and we're looking back. Okay. And then the last thing is just performing your own search, which you would do, using a secondary resource, PubMed, Ovid, Medline, Galileo. Those are all secondary resources because they're basically gateways to lead you to the primary literature. Okay? So Medline, I think of Medline as the actual data. Okay? It's basically the National Library of Medicine journal citation database. You see there's a lot, over 22 million citations, over 5,600 journals, so very in-depth. But the thing to remember is that pharmacy pharmacy is a very, very small component of Medline. If you were truly looking for pharmaceutical literature, probably something like International Pharmaceutical Abstracts would be a better choice, which is available through the UGA library. And there's not that many review articles actually indexed in Medline. So if that's what you're looking for, remember that might be a little bit of a limitation. And then even the systematic reviews, if you're looking for a true systematic review, you're probably going to go to the Cochrane Library and try to find those, because that group is really the most well known for that. And they use the National Library of Medicine medical subject heading or mesh terms. How many of you guys, when you do a search, actually use the official mesh terms versus just type it in with what you're thinking? Be honest, because I do it too. You just type it in. But it's very, especially in PubMed, they usually try to match up the mesh terms for you. You really want to do that because that's actually how it's indexed. So let's say I was looking for something related to TPN. I put in total parenteral nutrition, but it was actually in there, as, hyperalimentation. So if I'm not matching, I'm not going to be able to find the evidence if I'm not using the correct mapping terminology. So try to use the mesh terms when you're doing your searching from Medline. Okay, so PubMed, how is that different than Medline? It's basically the portal. I think of that as a search portal to access Medline. Did we lose somebody? Okay, and PubMed is probably broader than Medline. So you think of Medline being kind of that, the citation database from the National Library of Medicine. PubMed also includes other biomedical journals, so it's probably a little bit more broad than that. And all of the articles that you should be able to find in PubMed are in PubMed Central. Has anyone ever heard of PubMed Central? That's actually a digital repository for full text articles. Anything that has NIH funding will be in PubMed Central. So I have the citation here the URL here for you if you want to look at that. Okay. Ovid is a little different in that it basically is just an interface for searching Medline. So it's a subscription based, you think of PubMed being free. Ovid does require, a subscription, so it is fee based. We do have it here at AU, but a lot of other places may not actually use that. But it is just to search Medline. And then Galileo. How many people knew Galileo stood for Georgia Library Learning Online? Did everybody know that? I didn't know that when I first started looking at that. So this is actually an initiative from the Board of Regents of the University System of Georgia. What I like about Galileo is it actually highlights some of those things that you can't easily find in like PubMed. So Annals of Pharmacotherapy is one of the premier pharmacy journals, but it's not indexed in PubMed, or you can't access it in PubMed, but you can get it on Galileo. All right, so let's just talk a minute about the Cochrane Library. The Cochrane Handbook of Systematic Reviews and Interventions, if you want to look at like advanced search techniques, this chapter 6 that's in this document actually is very sophisticated, even more sophisticated than I would use, but it does go through like tools and things for advanced searching. So if that's something you're interested in, it is there. But Cochrane in general, that's where you're going to find all the, that's the best place to go for systematic reviews and meta-analysis. And Cochrane Central, I think, is a great resource to know about because there are a lot of things that feed into that that possibly you can't find in other places. All of the control trials that are like basically qualified for the systematic reviews can be found there. Embase, which once you get out in practice and you start trying to publish in a prestigious journal, what are the requirements is that you do an Embase search. We don't have Embase here. It's one of those resources that cost about, $10,000, something ridiculous that we don't have. But all the citations do feed into Cochrane Central. So I could at least make sure I haven't missed anything. Maybe there's something I might have to get as an interlibrary loan, but at least I would be able to see that. It also references conference papers and things like that, which you don't find that much in PubMed. So I think this is a good resource to know about. And this is just kind of showing you how all these things feed into that Cochrane Central. That there are a lot of things that feed into that. So that's like one source you can go, and it actually has citations from multiple places that might be helpful. Okay, Google Scholar is good. It does, you can access Medline by doing a Google Scholarship search, but one thing to note is that it could be a year out of date. So it may not actually have the most recent information. So as you're doing that, you might want to remember that. And then MetaSearch. Has anyone ever heard of a MetaSearch before? I can't remember if we talked about that at all. I just listed two here for you. SunSearch 2 and Trip. What's really interesting about these, and I never think about using them, to be honest with you. I tend to do search the old-fashioned way, but this does actually pull things from multiple places. So it pulls guidelines, it pulls primary literature, it goes across multiple databases, so it pulls it all into one search. So you might just for fun do your seminar topic and just see what kind of things you find with that. But SunSearch 2 and Trip are the two that I've seen the most. This is, I don't think I put this in your handout, but if you want to write down this URL over here on the right, this just actually shows you the breakdown of where, like for the Trip database, where it's pulling. This is like the top 500 journals, like that, based off their impact factor. So just kind of walks you through where all the information is coming from. Okay, so I'm not going to really go over the next couple of slides. This is here. Remember when we were talking about PICO, and I said sometimes I like to include the S of something about the study design. If you think about the type of search that you're doing, it's probably going to fall in one of these 5 categories. It's either related to therapy, it's either harm, diagnosis, differential diagnosis, or prognosis. So I just have a couple of study designs and search terms that might help you narrow your search, make it a little cleaner as it relates to the type of information you're looking for. So anytime you're looking for something with harm, it's probably going to be an observational study, right? Because we can't really set up a study to see if it harms somebody intentionally, right? So it's probably going to be a cohort, which would be an observational study, a case control trial where you're looking at people already have the outcome and you're kind of looking backwards. So that's just a little bit of terminology that might help you. Okay, so each one of these just go, this one's for therapy. These are just some terms that will be helpful for therapy. This one's on harm, so cohort, putting cohort in your actual search or case control study, differential diagnosis, and then diagnosis. Anytime you're talking about diagnosis, sensitivity, specificity, positive and negative predictive value, all of those would be good terms to actually include. Okay, and then prognosis would be like disease progression, natural history, those types of, that terminology might be helpful for you. All right, so now let's talk a little bit about evaluating the evidence. We've already talked a little bit about external validity. That is really the generalizability. So if you have a study that's in a very specific patient population, can you really apply that to a broader population? And then internal validity, that's kind of what we do in journal clubs, where, and you guys are going to do this in a couple of weeks when we do the journal clubs in APP, actually evaluating the study based on its design, the methods, and the results that you want. Okay, this is one of my favorite slides too, because when you're doing a search and you're trying to figure out, we are so busy and it is so hard to find time to keep up with the literature, let alone if you're just trying to answer a question about So when you take the time to read something, it really needs to be something that is going to be beneficial. So like this is kind of what I use to say, is this worth my time to read or not? You know? So how relevant is it? Is it applicable to the patients that I'm taking care of? Is it going to change the way that I actually care for the patient? And if it is, you know, that's what I use the abstract for. Read the abstract, see if that makes sense to me. And if that's okay, I say, okay, well, then let me look at the validity of the trial. That's where I do the internal validity, actually looking at it. Because it truly is a balance of how much effort it takes to do that versus, you know, what you're going to get out of it. And this is just a little checklist. If you're struggling about what you need to read on something, ask yourself these questions. And if you get a yes, keep on going. If you get a no, say, maybe this isn't the one I need to read. So, you know, again, even if you have 5 studies, you probably want to read the 2 that are going to, you know, be the most impactful. But the bottom line is it going to change the way you treat the patients? What kind of outcomes were they looking at? Okay. And this goes back to dose and points. Think of dose as disease-oriented evidence. That's surrogate endpoints that tell us something about a certain disease versus patient-oriented evidence, which is like, you know, increased survival, decreased stroke, you know, those kinds of things. And the reason you got to be careful about going just off of surrogate endpoints, there's been many examples in the literature where this has gotten us in a little bit of trouble. So think back, so this was in 2002, think back to where, you know, before then where we used to do a lot of postmenopausal, you know, hormone replacement therapy. And we actually thought it was going to be beneficial for the heart too, because it decreased LDL, it increased HDL, all those things we know, you know, may improve cardiac health. So it seemed like it was a win-win. Well, all of the data with hormone replacement was really based off of observational studies. So again, you can't show cause and effect. When they finally did clinical trials on this, we found that there was an increased risk of death in those patients. So you can't, sometimes it doesn't always correlate that it's going to be a positive outcome. And the reverse was true with beta blockers. You know, we go back, I use the Rails trial for a lot of examples because it's such a great trial for looking at relative risk and a lot of other things. You know, if you look at how many people, that was 1999, we look at how many people were actually on beta blockers, there were not that many, maybe 10%. And now think about it, you have heart failure patients not on a beta blocker, but we thought that it actually would be harmful based off the way it worked. They would be harmful in patients who had heart failure. Then, you know, HF came out, you know, many others have come out, but now we know that that's actually not true, that it's actually beneficial. Okay, so how can you get better at actually analyzing the data that you're looking at? You really should, in the beginning, use some kind of checklist. I gave y'all a checklist second year during 4700. It was just a general one for randomized controlled trials. But if you're using some kind of checklist, at least you're looking at all the important things. So it's a good way to get started. What I would recommend is that you use a checklist that's specific for the type of study that you're using. Pharmacist Letter has some things that are really good. But Consort, this is a website that you can go to, it's free, but they have checklists for every type of study you can think of. Pragmatic trials, randomized controlled trials, cluster trials, non-inferiority trials, and you probably should be using a checklist that's very specific for the type of study. PRISMA is the group that puts out the checklist for systematic reviews and meta-analysis. PRISMA stands for Preferred Reporting Items for Systematic Review and Meta-Analysis. So as you move forward with APP and you're going to do Journal Club, I would recommend that you use the Consort, you know, and use that as you're evaluating the articles. You also can look at the grading of the systems. There's a lot of different ones. This one is called the grades system or work group, and it looks at the quality and the strength of the evidence. So, you know, we think about the strength as, you know, is it good evidence, poor, moderate, and then the quality is like, you know, how many informational. And a 1A is really considered the best evidence. Okay, so this is just an example of, we talked about the Rails trial, using aldosterone antagonists such as spironolactone in heart failure. That's where that basically came from. So this is just an example of what that looks like in the guidelines. And then, you know, one thing I like about talking about measures of association, relative risk odds ratio, and then looking at absolute risk reduction, numbers needed to treat, numbers needed to harm. Those are tangible things that you can look at when you're evaluating the literature. You know, when you have a relative risk of 70, well, you know relative risk reduction is really the important part, right? So 1 minus relative risk is relative risk reduction. 30% reduction in death using spironolactone in heart failure patients, stage 3 or 4. So, you know, that's like a little bit more tangible. It makes a little bit more sense, I think, when you're talking about it. This is a chart in the Rails trial showing you the 70%. And I have this in, I think I have it in your handout about what the numbers look like. Drug reps will come in and say, well, it's a 70% reduction. Why would you not add that to your formulary? It's very intimidating when somebody does that, and even physicians around. So being able to interpret that and say, oh, what this really means is this, really helps you be successful with your recommendations. But the numbers needed to treat, which is 1 over absolute risk reduction as a fraction, is not for the Rails trial. You only have to treat 9 people with spironolactone 25 milligrams for like a year, whatever the length of the study was, to prevent a death. I mean, that's pretty impressive, right? And the study got stopped early because of that. So that kind of helps you kind of analyze the information a little better by using these tools. All right, so now once you've done all that, you've got to apply it to your patient. And I don't have a whole lot on that, but I think the key here is just that you make sure that your patient falls into that category. When you're evaluating the evidence, is that the patient, when you're applying it to your patient, is that the patient who actually got that? Cisapride was a great prokinetic drug. We don't really have good prokinetic drugs, right? We have Reglan, which has a ton of side effects. The reason it got pulled from the market is because of drug interactions. It's a 3A4 inhibitor, you know, and it interacted with all these drugs and caused torsades, killed a lot of people. But it was a great drug. If it had just been used the way it was studied, which they looked for those types of things, the drug probably would still be on the market today. So you got to make sure that you're applying it to the patients that were studied. And that's where you can get in trouble when you do a lot of extrapolating from that. Okay, so hopefully this gave you some tools to take away why evidence-based medicine is really important. It should help you focus your literature searches. It should give you some skills when you're trying to interact with patients and other healthcare providers. Excuse me. It helps you stay up to date. You know, it's a good way just to stay up to date and you know, kind of keep you at the top of your game. All right, that's all I got. Does anyone have any questions? All right, I think the test questions will be pretty straightforward. They'll come directly from the material we talked about.